Hello, everyone, and welcome to Assessing and Diagnosing Autism Spectrum Disorder, the second webinar in the Florida Institute for Child Welfare's Autism Awareness webinar series. Today, we're joined by Shannon, Bennett, and Alicia Nohle. Shannon is the director of the Multidisciplinary Center at Florida State University. She is also a licensed psychologist and licensed school psychologist who has been practicing since 2014. Alicia is the assistant director of the Multidisciplinary Center at Florida State University, and she is a licensed clinical social worker and licensed marriage and family therapist who has been practicing since 2006.
Thank you so much, Zoe. Good morning, everyone. My name is Shannon Bennett. I am the director at the Multidisciplinary Center here at FSU. We're actually neighbors with FICW, so we're right next door. And I am here with Alicia Nohle, who's our assistant director, and we're going to be talking about assessing and diagnosing autism spectrum disorder. That is our specialty here, one of our specialties here. I just want to put a little disclaimer out there. Our focus is on diagnosing and assessing in childhood. And I put that out there just because I know there's a lot coming out in terms of identifying autism spectrum disorder in adulthood, or young men and women trying to figure out, do I have ASD once they get to college and they're realizing things are a little bit different. But our focus is on childhood. I am specifically trained as a school psychologist, so I work with school-age children, and I'll speak to a little bit of ASD on the school side of things as well. And Alicia Nohle may want to talk a little bit more about this, but she has seen kids as young as, I think, 12 to 18 months. And then goes all the way as well through school age. So that's just a little bit about us and what our focus will be. Please feel free to ask questions as we go along. We'll try to catch them, and we may answer them as we talk throughout the presentation. And then again, like Zoe said, at the very end, we will have time for Q&A. Let's talk about just briefly what autism spectrum disorder is. And we're taking this directly from the DSM-5, which is our manual in diagnosing. And you all may be a little bit familiar with this already. We're training site too. And one of the things that we tell our trainees right away is, if you see one child with autism, you've seen one child with autism, because it can look so different. It is truly a spectrum. So for example, you see on this slide here, some of the things that people often think about is lack of eye contact, or they don't want anything to do with social interaction. And while that may be the case for some individuals with ASD, that is certainly not the case for all. And it can look so different from person to person. So broad definition of what autism spectrum disorder is, according to the DSM, it's a neurodevelopmental disorder. So that means it's brain-based, it's happening and it's occurring, it's starting during that developmental period in childhood. And that's characterized by persistent deficits in social communication and social interaction. And we'll talk more about that. Alicia will talk to that and dive deep. Accompanied also by restricted, repetitive patterns of behavior, interests, or activities. So a lot of things can fall into those two broad categories, and we'll kind of tease that apart just a little bit.
Hey, good morning. So I want to talk a little bit about that diagnostic criteria for autism. Again, this is taken directly from the DSM criteria. And there, as Shannon was saying, there are two broad areas that we're looking at. We're looking at social communication and social interaction, and then, of course, restricted and repetitive interests and behaviors. And I think that's what comes to mind more often are those, because they're a little bit more obvious. When it comes to that social communication, what we're looking for are deficits. So we're looking for the things that aren't there, or aren't there to the extent that they should be for a child's age. Social communication encompasses that reciprocity between individuals, whether that is actual conversation, whether that is nonverbal communication, or coordinating that together. And it's also that maintenance of relationships. So when you have deficits in social communication, not only do you have difficulty expressing to other people what it is that you want to get across, but you also have difficulty interpreting those those communication clues coming back from someone else. So really that social communication area, we're looking at those deficits, and we're looking at these three different areas. So we have that social emotional reciprocity, nonverbal, and maintaining relationships. And we have to see evidence in all three of these areas across contexts. The other area is restricted and repetitive interests and behaviors. So when you think of restricted and repetitive interests, a lot of times you might think of repetitive motor movements, repetitive verbalizations, and those are definitely symptoms that you can see. They can also be an intensity in certain interests. And where it gets a little bit tricky is sometimes those interests are very appropriate for a child's age. It's just the intensity of them is what is unusual. And then, of course, there's also unusual interests, which can be very fixated and unusual in nature, which might be something either really advanced for that child's age, where you might have a preschooler who's interested in intense aspects of space, or might
knows
have
every aspect of like luxury cars is one
right, exactly,
that we see. Yeah.
And they tend to know a whole lot more information about those topics than you would expect for a child that age. They can list all of the facts. They can tell you, they can identify. So maybe, they're interested in dinosaurs, which isn't unusual maybe for a 4-year-old, but listing every single name of every dinosaur by sight and all of their characteristics is a little bit more unusual. Another thing that you might see with restricted and repetitive behaviors is this rigidity with routines. Things like not being able to move on if a particular routine is not completed. Rituals, which again can be a little bit difficult sometimes in early childhood to tease apart, because that's how we teach. That's how we teach preschoolers and toddlers, is through routines. But when it becomes a situation where a child has a whole lot of difficulty, is having meltdowns because they weren't able to finish the routine to completion, or weren't given enough of a heads up before actually transitioning to the next activity, that's when you know that it's a little bit out of the range of ordinary. Another area that falls underneath these restricted and repetitive behaviors is actually hyperactivity or hyporeactivity to sensory input. So that would be things like noise, being noise sensitive, being sensitive to lights, touch, the feel of clothing, tags in their clothes. And that would be more of that hyporeactivity. Or hyperreactivity, I'm sorry. Hyporeactivity is that sensory seeking. I need so much more. I need that deep pressure. I need so much more information to be able to be okay with it. And those are those sensory aspects of the environment. Symptoms have to be present in early childhood. They aren't always apparent in very young children in their entirety. Some of the younger children that I've seen, the symptoms are just starting to unfold and tend to then unfold into that late toddler, early preschool age. And then symptoms also have to be limiting in everyday function, whether that's in school, at home, or across environments. There has to be evidence of impairment.
So let's talk a little bit about diagnosis versus eligibility. So what Alicia just walked you through was that clinical diagnosis, and we'll talk a little bit more about that and what that looks like when families and caregivers bring their kids in to get a diagnosis and why. But there's also this idea of eligibility related to schools. And eligibility is not a diagnosis. That's a little bit different. And so there's definitely an overlap in what the definition looks like between a DSM diagnosis and the educational category of autism spectrum. However, a diagnosis does not guarantee an IEP or services in the schools. They're completely separate. One of the really great analogies that I've heard a school psychologist say is it's like a diagnosis and eligibility are on two completely different train tracks, but they're running parallel to each other. They never cross over. They're going towards the same destination. They may be near each other, but they never cross over. So again, that diagnosis is not a guarantee of an IEP. And vice versa. If a school finds a student eligible under the category of ASD for an IEP, it doesn't mean that a private practitioner is going to provide a diagnosis. They still have to do their own assessment and find it through the DSM that they meet this criteria. Oftentimes they overlap, but not always. We do recommend when caregivers come over to us, to our clinic, to go ahead and share the report with the school district just so that they have it and they recognize it. But again, they have to do their own evaluation process in the school. And the reason why sometimes caregivers, because one of the questions may be, well, if I need services in the school and I go through the school, why does a caregiver even or a family need to find a clinical diagnosis? And it's usually for insurance purposes or getting services in the community. Oftentimes the reports that are generated in the school for eligibility don't have a diagnosis on it, or the school psychologist who has done the evaluation is not recognized by the insurance carrier. So they need a clinical diagnosis for that.
I'm sorry, there's a question in the chat about autism versus ADHD and whether it's common to be co-occurring.
Yeah, that's a great question. They are definitely, we see some overlap in terms of it being co-occurring. It is actually something that we do take a look at. And one of the things that Alicia mentioned earlier was that hypo or hyperactivity piece to it. That is something that we can see that overlaps sometimes between the two diagnoses. So a child can have both. I will say, I don't know that I often see if a child has ADHD, that it's masking symptoms of ASD. It can absolutely happen, but oftentimes we see symptoms of both occurring. Would you say that's true in your experience too, Alicia?
Yes, I would say that there are definitely symptoms that overlap. A lot of that, things like not being aware of social cues can also look like impulsivity and vice versa. Fleeting eye contact because of distractibility can look like difficulty with eye contact. So there are definitely symptoms that overlap. But there are then those symptoms that are there that with ASD that really just aren't there with ADHD.
Right.
So things like those intense aversive behaviors. But that said, they absolutely can be comorbid, and we have seen, many kids that have both ADHD and ASD.
Absolutely.
ASD typically tends to be able to be diagnosed younger, though.
Yes, absolutely. So just kind of how we went over the DSM diagnosis related to ASD. We have a slide here related to school eligibility requirements for exceptional student education. So the definition is actually very, very similar. It's a condition that reflects a wide range of symptoms and levels of impairment, which vary in severity from one individual to another. Autism spectrum disorder is characterized by an atypical developmental profile with a pattern of qualitative impairments in social interaction and social communication. So that first piece that Alicia talked about, and the presence of restricted or repetitive patterns of behavior, interests, or activities which occur across settings. And that's that second part she alluded to. So it's, a very similar definition here. So they have to meet all of those criteria. And then if you look at the very bottom of the slide, there needs to be a connection showing that the child is indeed in need of special education. So it's not enough to come with that clinical diagnosis. If they're doing well in their general education classroom, if it's not impairing to them, a school may not find them eligible for an IEP in the school. There is something separate called a 504 plan that they may be eligible for, like for accommodations, but an IEP is giving them something different from their general education peers, whereas a 504 is accommodating within the general education environment. So there are ways to help that student if they need help in the school. But again, what we're trying to get across is a clinical diagnosis is not necessarily a guarantee of services in the school setting.
Okay. So a clinical assessment has several different pieces to it. We don't just diagnose based on one measure or one tool. What's really important that often gets a little bit overlooked is that psychosocial developmental history. Typically in a clinic setting, that is done with a parent or a caregiver that is very familiar with the child. Usually that is a parent. Occasionally it can be a guardian if a child's if they've been with the child for some time. And that also includes an adaptive behavior measure. Now, the adaptive behavior measure is not a measure of what a child is able to do, it's what a child is demonstrating, which can sometimes be very different things. Kids can often have these abilities, but if they're not given the opportunity to do things, or if they aren't made to do things, it's not required of them, then they're not actually demonstrating those things. And so adaptive behavior is often, Shannon, correct me if I'm wrong, but it's utilized in planning for, intervention planning.
Yes, yeah, absolutely. It's not something that's necessary for that diagnosis of ASD, but it is something that we have to answer to in terms of where they're functioning. It helps us figure out what types of recommendations we may want to have in place. And then also at our center, we try to fulfill everything a school might need, and a school absolutely requires an adaptive behavior measure too.
We also like to get checklists from both parents and educational representatives, whether that's teachers, tutors. If a child is homeschooled, you can get a checklist from a tutor or a homeschool co-op teacher rather than, a classroom teacher. Partly because we need to see these behaviors unfolding across environments. And so we need to have data from different environments included. We typically will do an IQ, achievement and process assessments so that we can rule out any learning issues or global developmental delays. And then in our clinic, we also do the Autism Diagnostic Observation Schedule, which is the ADOS-2. That is the gold standard for assessments. And that is an autism specific measure where it's a structured play sample that kind of sets up situations in order to observe a child's communication, both verbal and nonverbal. It assesses their play skills, it assesses their ability to ask for information of someone else, share information, carry on a conversation, those types of activities. And then as needed in a clinical setting, we will do additional clinical interviewing and direct observation in the school setting if questions about interactions with peers, or if we're questioning perhaps a differential diagnosis. That psychosocial and developmental history, like I said, is very important. There's a lot that goes into that. It usually takes about 2 to 4 hours to complete. For older children, verbal children, we tend to do that interviewing while they're being tested with the parent. For younger children and nonverbal children, we do have to have the parent in the room as part of the assessment process, so it may be completed at a different time, a separate time, or over the phone. We want to know what these parents' concerns are from their perspective, what they're seeing at home. Sometimes that can be very different from what a therapist or a teacher is seeing at school, or what is being communicated to the parent by the doctor. We want to know about their early gestational and birth history, their early development and milestones, if there were any early delays, if there are, because we're looking at these very early signs and symptoms that may have been there before a parent even had concerns. We're looking at their medical history. Is there any other medical issues going on that may be accounting for some of these symptoms, something like epilepsy and seizures, or some sort of genetic issue? or celiac? Are they having issues with, dietary issues? We're also looking at sleeping and eating patterns. Do they have a healthy sleeping pattern routine? And what are their eating patterns look like? Are we seeing anything within those patterns that is falling in that restricted and repetitive area, which is a lot of times where we might see it, some sorts of aversions to textures, or we might see routines around meal times that are very specific. We also want to look at family composition and dynamics, what the whole overall household looks like. If there's more than one household where this child spends time, we want to kind of know what the dynamic is in each of those households. What kind of intervention this child has had, and what their educational history has been, if they've been in public school, private school, homeschooled, and how early did they start school and have that exposure. We ask about peer relationships. So we're looking at peer relationships in school, but also in extracurricular activities or in unstructured activities like birthday parties at the park, things like that. And then their interests in activities. Do they have a variety of interests? Do they, or are they really focused in on one particular type of activity or one particular topic or character? And then also behavior patterns. And like I said, a comprehensive history will typically take about 2 to 4 hours to complete. The adaptive behavior measure usually goes along with that interview whenever possible. At times we have to do that separately, but it's looking at their functioning from day to day. And we always, let the parents know this is not something that is what they're capable of doing, but what they're actually demonstrating. And, a child cannot get credit for something that they haven't had the opportunity to demonstrate, or if they aren't doing it completely independently. For example, if I ask a parent, are they bathing on their own? And the parent says, oh yeah, absolutely. I just help them wash their hair. That's not actually independently. So unfortunately, they can't get credit for that. So it needs to be skills that they are demonstrating in their entirety when it's necessary, when it's required, on a consistent basis. So as obviously it's an adaptive measure is something that is best completed by someone who knows the child very well. There are teacher versions as well, and occasionally we will do a classroom version with a teacher on top of that.
I'll talk a little bit about the social emotional behavioral checklist. As you can see already, like if you're following along or maybe lost a little bit, there's a lot that goes into these evaluations. And so another piece is we're collecting this information from parents, caregivers, through an interview process. But what we also want to do is get normative data, meaning we want to be able to see, okay, how different are these symptoms that this child is exhibiting or experiencing from other kids their same age or their same age and gender? And that's what these forms allow us to do. So we usually do a broadband measure, which is capturing not only maybe some of the symptoms associated with ASC, but it's also going to look broadly at other difficulties, behaviors, social emotional functioning that can occur in childhood. Things like ADHD, which was mentioned earlier, or even things like anxiety. Social anxiety is a big one that comes up often when there's a question about ASC because they're anxious socially too. We're looking at things like depression as well. So some of those internalizing things, as well as some of the externalizing things like aggressive behaviors, oppositional behaviors, rule-breaking behaviors. So that's what we mean in terms of broadband. We want to look broadly, what is this child, not only in autism, but broadly, what is their behavior and emotional functioning looking like? You can see there's many different forms out there. These are just some of the ones that we regularly use. And then in addition to a broadband measure, we want a narrow band measure looking specifically at symptoms of autism spectrum. How many of these symptoms do they have compared to others? Is it crossing a clinical threshold? And then again, compared to others, is this others their age and their gender? Is this out of what we typically find? Is this out of the norm? the list that we have here again is typically what we see, but it's not an exhaustive list. There are other things that can be added, other measures out there that are used by other, practitioners that we may not be using. But the big thing is collecting that information, having that information, both from the caregiver, the home context, and the school context if they're in school, or if they're not in school, someone else who's familiar with them. That could be someone like a speech language pathologist, a tutor, some other provider. It could even be someone if there's like a faith-based entity that the family visits often. We will pull from other people because we want as much of that information as possible. The other thing that we're doing as part of the evaluation process is psychoeducational testing. So the psychoeducational testing is usually a full battery of direct testing with the child to look at differentiating any developmental delays that may be related to the symptoms of autism. So it really depends on the age of the child and what we're doing, but it could include a developmental assessment. If the child is older and able to withstand an IQ assessment, we will do that as well. Look at their IQ, their problem solving, their verbal skills, nonverbal skills. We'll also look at their academic functioning. Again, the academic functioning piece is not necessary for diagnosing. However, it's very helpful if they're going to be sharing this with the school. So we'll look at what their skills are like in terms of pre-academic skills, as well as in reading, math, and writing. And then we'll do additional processing measures as necessary. And again, as much as the child is able to do that day. And so you see that note down there, the testing, this direct testing is in assessing for symptoms of ASD, although we may see some during the testing, and we'll make note of that. It's not directly evaluating for that. We have to establish that the symptoms of ASD are not explained by an intellectual or global disability. So we have to have some data on that. The other thing that we have to do when we're diagnosing ASD is specify whether or not an intellectual impairment is present if we are diagnosing. So that's why that direct testing is pretty important as well.
Okay. As I mentioned before, the autism specific testing that we use is the Autism Diagnostic Observation Schedule. The ADOS has 5 different modules that go from 1 to 4, and then there's also a toddler module. Typically, the module is determined based on language level. However, the toddler module is used up until a specific age, and then up to 31 months. And then after 31 months, it will switch to module 1 if a child is still nonverbal. You can also use a higher module if you do have a highly verbal toddler. A toddler can jump from a toddler module to a module 2, which is phrase speech, or a module 1. But typically you're going to use the toddler module if they don't have any language. You're going to go by age first. The other modules all look at language as that kind of baseline for determining what module to use. Module 1 is nonverbal or single words. Module 2 is flexible phrase speech. Module 3 is full sentence and conversational language. And then module 4 is very similar to module 3, but it is for young adults, older teens, ages 16 and up, and the reason being is that it just has different questions about things like work and relationships and budgeting and things like that wouldn't be appropriate for younger kids. The module 4 is also used for adults when they're being assessed. The ADOS is considered the gold standard. It's a very valuable tool, and I would highly recommend that it is a part of any comprehensive evaluation that you're seeking out. That said, it is one piece, and I wouldn't ever diagnose autism just based off of this one measure. I don't think that that's something that you can effectively do without all of those other pieces giving you that big picture.
So some additional optional assessments. The brief observation of symptoms of autism, we call it the BOSA. That is actually something we started using during the COVID days when we were trying to minimize exposure. And essentially what the BOSA did was allowed us to still see this child in a play situation, whether it be in our clinic or remotely, but it was the caregiver that, or the parent that was interacting with that child in the play situation, with us specifically telling the caregiver kind of what to do and setting them up with the situations that we want to see that would maybe for some elicit some of those symptoms that we're looking for when it comes to autism spectrum. We do not use the BOSA often. We find because we're fully in person. We love to have the kids come in. We love to go out and do school observations if it's necessary, so we can directly see that child. And we do, especially for our young kids, the caregivers are in the room with the child on some of those earlier modules, so we'll get to see some of that interaction as well with their caregiver. The systematic observation of red flags, or the SORF, we use pretty often if we are doing a school observation. That's what we're using. And it allows us to kind of qualify and quantify what we're observing in the classroom, or what we're observing in the lunchroom or at PE in these different situations where we're watching this child at school. And not only qualify, but we can quantify it too. How frequently is it happening? And so it can be a very helpful tool, and we're using it especially when it's for school-based eligibility. It's a really nice tool because oftentimes, depending on the school district, they may not be doing the ADOS, or depending on the practitioner, they may not be certified to do the ADOS. And so the SORF is a really nice tool when observing for those symptoms. And again, we can include additional checklists, include additional interviewing to rule out any differential diagnoses. So if there's a question of ADHD as well, or if there's a question of social anxiety as well, we may add in some additional checklists, may add in some additional interviewing. And depending on the age of the child or the adolescent, we may also directly interview that child who is the one that is there for that assessment. The school-based assessment is very, very similar to what we're doing in the clinic. We're still doing a psychosocial developmental history. We're still doing clinical interviewing. We're still using those checklists, broadband and specific to ASD. We're still doing the IQ, that adaptive assessment. The difference is the classroom observation is absolutely necessary. We have to do that. It is not a necessary thing as part of the DSM or the clinical diagnosis. And that's where that SORF comes in. And it probably shouldn't say school classroom observation. It really needs to be a school observation. It can happen in the classroom. It can happen in the lunchroom. It can happen at recess. And actually recess and the lunchroom are probably some of the best observation areas because there's a social component to that. It's also loud if there are any sensory things for that child. We can kind of gauge and see what's happening. And it gives us a direct comparison of the child and their peers, their classroom peers. We can see, are we seeing any differences in the way that they're interacting? Are we seeing any differences in the way that they're handling their peers approaching them, or the way that they're approaching their peers? So that is absolutely necessary as far as the school eligibility. It's also a language evaluation is required as part of a school-based assessment as well. The psychologists are actually, and the social workers are not the ones who do that. That is the speech language pathologists. And then we also have to have sensory screenings done. And that's really a screening of vision and hearing. We need to know that these symptoms are not a result of any vision or hearing impairments. Although they can co-occur, you can have a child who has a vision or a hearing impairment that also has autism spectrum. We need to know that they're being able to access the information in their environment visually and auditorially as well. So what can caregivers expect? So whether it's a school-based or clinic-based evaluation, as you can see, there are a lot of components to assessing and evaluating for autism. Specifically in a clinic, and this may vary from clinic to clinic. This is mostly what you could expect if you were to come to our clinic. And I know a lot of the university-based clinics operate the same way because we're working in best practice and trying to be as comprehensive as possible. But what you can expect is if we are going to do a classroom observation, if it's needed, it's going to be done prior to the evaluation. That's usually about an hour to 2 hours where we're going out to the school. We also want to talk with the teacher a little bit too if we're going out to the school just to get an idea of what they're seeing. So there may be a little bit of a mini teacher interview. The in-clinic appointment varies, the time varies depending on the age of the child. It can take anywhere from about 4 to 6 hours. And that is in our particular clinic, we are working as a team. So we have folks who are working with the parents and the caregivers to get the interviewing done, while someone else is separately working with the child to get the testing done. If the child is younger, there needs to be another caregiver that's there because they often have a hard time separating from their caregiver. So we try to get it all done in one day, but sometimes if that caregiver, if we can't do all the interviewing, we may need to do a separate interview with that caregiver on a different day. We try to avoid that, but sometimes it happens just depending on the age of that child. And younger children usually need their caregivers more. But again, it encompasses all of the interviewing, the testing, the collection of the checklist. We score the checklist, and all of that. And once we have all the information, we are writing up a report. And regardless of whether or not we've made a diagnosis, there are lots of recommendations in our reports because there's a reason families are coming to us. Even if it's not autism, well, what is it? If we can't quite answer what it is, well, what can I do? And we try to give that to our families. And our reports are usually ready about 4 to 6 weeks after the evaluation. As I mentioned earlier, we are a training clinic, so we operate off of that training schedule, and that's why it can take a little bit longer. But once that report is done, we have a meeting and we go over the results together with the caregivers so they know exactly what's in the report, what if we gave a diagnosis or if we didn't, and what the recommendations are, what the family should do from there. What can caregivers, parents expect for a school-based evaluation? Very, very similar, but it's all done at the school. The caregivers are not having to come into the clinic. They're rarely even having to come to the school unless they prefer to do that psychosocial interview. But we're collecting all that same information over multiple days in the school setting. The ADOS is one of the things that usually is not done. Again, a lot of our school practitioners are just not trained on it or there's not time to do it. So that's why that observation in a social context at school is really, really important. One of the other things to know is an evaluation in the school setting has to be completed 60 calendar days following the consent for the evaluation that caregiver has signed. And once the report is ready, there's a meeting. It's called an eligibility or a staffing meeting. It includes everybody who is involved in that evaluation and everybody who is involved in that child's education. So the caregivers, the parents, general education teacher, ESE teacher, the speech language pathologist, school psychologist, and sometimes like the occupational therapy, if we found that there are some fine motor concerns, for example. So it's very collaborative and multidisciplinary within the school setting as well.
Just a little bit of additional information for parents. When you're working with families is to let them know that most clinics are going to have a wait list for scheduling an autism assessment. Wait times can vary from 6 months to up to 2 years. So I would encourage, any families that you're working with, if they have concerns, encourage them to at least get on a wait list. If they get a call to schedule 6 months down the road or a year down the road, and they don't have concerns any longer, that's fine. They don't have to schedule. But better to go ahead and get on a wait list when they have any concerns at all, even if their pediatrician is dismissing them. Better for them to kind of follow their gut and get on a wait list so that they don't then get to a crisis point and then they have to wait another year to get an assessment. Even though schools have to complete an assessment within 60 days, that's 60 days from consent. That doesn't mean that it's going to necessarily happen a lot faster at the school level. It just means that they're going to wait to sign that consent with the parents until they know they can complete that assessment within the 60 days. Assessments in a clinic may not be covered by all insurances, and they can be private pay, but I would definitely recommend that if a client does have insurance, that they contact their insurance company first, find out who their providers are and who in network, and then try to get on those wait lists, even if they have other out-of-network options they want to explore. Like I said, they can pay privately. An assessment for autism is typically, as you can see, it's very comprehensive and very time consuming, and fees do range somewhere depending on where you're at and what city and where in the state you are, or where in the country. They can vary from $1,000 to $5,000, depending on where they are. Autism can be assessed, or there are pieces of it that can be assessed by many different professionals, but it can only be diagnosed by a licensed psychologist, a psychiatrist, or a developmental pediatrician. So while a social worker, clinical social worker, or a speech pathologist, or a PT or OT may play roles in that process, they cannot on their own provide a diagnosis. So if you have a parent coming to you that says, oh, I have my child's mental health counselor gave them a diagnosis, they absolutely did not. They may have done different pieces, but they really, if they did give a diagnosis, they shouldn't have, and it's not going to be accepted by either insurance or school districts. Especially the school district is going to require a licensed psychologist or a certified school psychologist, even above a developmental pediatrician. One thing to keep in mind also with your families is that autism is a spectrum disorder. Symptom presentation is going to change over time as the child grows and develops. Different new symptoms may come out. It may ebb and flow, especially if they're going through transitions. They're changing schools, they're changing homes, they're going from elementary school to middle school. So they may be doing really well and seem to be doing, they have these supports in place and everything's going well, but then there's some sort of change and they backtrack, and more you see newer different symptoms come out, or they increase in intensity until that child then, gets acclimated to the new situation. So all that to say, you should be assessing the supports that they have at regular intervals, and making sure that they have what they need, because what they have and what they need at 4 years old is not going to be the same as what they need at 10 or at 15. It's not a one size all type of intervention. So, what works really well for one child is not necessarily going to work for another child. And so while there are lots of different interventions, they're not all going to necessarily, not everyone with autism needs ABA therapy, and not everyone needs speech therapy. You really have to pay attention to the presenting symptoms with that child and, tailor it to what they need.
So, great question from Artemis. Would an LCSW have the ability to give an ASD diagnosis? And Alicia, before you answer this, I want to say this is specific to Florida, and what Florida schools and Florida, most Florida insurance companies that we know of in our region, how they respond to these diagnoses. This could be different in different regions of Florida, as well as different regions across the United States. But Alicia, I'll let you answer that one because you're also an LCSW.
Yes, I am an LCSW. And yes, an LCSW can give a diagnosis. However, that diagnosis will probably not be very useful for the parent. I diagnose children that I have assessed through our clinic but I always do it in conjunction with one of our psychologists and review everything with that psychologist, and they also sign off on my reports. If I were to, even though I have had specialized training in autism and I've been doing it for years, if I were to just send one of my reports to a school district or to an insurance company, it likely would not be accepted.
And again, that may vary. Those, schools or insurance companies, it may vary from state to state. That's just what our experience has been here. And we serve, I should say also, we serve schools in kind of our region that we serve is all the way from Escambia County, Pensacola, to Madison, Taylor County, if you guys are familiar with that, and everything in between. So that's kind of been our experience for our region. Well, that's what we have for you all today.
And before we close out, I just want to do a round of applause and big thank you to our presenters. Again, thank you so much for being with us today and sharing all of this wonderful information.
Welcome. It was a pleasure.